Managing diabetic ketoacidosis, or DKA, is a medical emergency requiring prompt correction of dehydration, electrolyte imbalance, and insulin deficiency. The first critical step in DKA management is fluid replacement, as patients are typically severely dehydrated. Initial management begins with 0.9% normal saline at 15 to 20 ml/kg in the first hour to restore intravascular volume. Subsequent fluid choice depends on corrected serum sodium, 0.45% saline if normal or high, 0.9% saline if low. Once plasma glucose falls to 200 to 250 mg/dl, fluids are changed to 5% dextrose with 0.45% saline to prevent hypoglycemia. Next, insulin therapy is essential to suppress lipolysis and ketogenesis, key processes in DKA. A continuous intravenous infusion of regular insulin is preferred, starting with a bolus of 0.1 units/kg, followed by an infusion at 0.1 units/kg/hour. The goal is to reduce plasma glucose by 50 to 75 mg/dl per hour, carefully managing blood sugar levels. When glucose reaches 200 to 250 mg/dl, insulin infusion is reduced to 0.02 to 0.05 units/kg/hour and continued until ketoacidosis resolves. Potassium replacement is vital, as total body potassium is depleted even when serum levels appear normal or elevated. If serum potassium is below 3.3 milliequivalent/L, insulin should be withheld and potassium administered until it rises above 3.3 milliequivalent/L. If potassium is between 3.3 and 5.0 milliequivalent/L, 20 to 30 milliequivalent potassium should be added to each liter of fluid. If above 5.0 milliequivalent/L, potassium supplementation is withheld, but levels are monitored closely every 2 hours. Bicarbonate therapy is generally avoided unless arterial pH is below 6.9, as correction occurs with insulin and fluids. If used, 100 mol of sodium bicarbonate and 400 ml sterile water with 20 milliequivalent KSL over 2 hours is recommended. Phosphate replacement is considered only if severe hypophosphatemia, respiratory or cardiac dysfunction, or hemolysis occurs. Continuous monitoring of vital signs, fluid balance, capillary blood glucose hourly, electrolytes, renal function, and acid-base status is crucial. The underlying cause, such as infection or missed insulin doses, should be identified and treated appropriately. Once the patient is stable, ketoacidosis resolved, and oral intake tolerated, transition to subcutaneous insulin is made. This transition involves overlapping with insulin for 1 to 2 hours to prevent rebound hyperglycemia, ensuring a smooth recovery. In summary, DKA management pillars are fluid resuscitation, insulin therapy, electrolyte correction, monitoring, and treating the cause. These combined efforts ensure safe recovery and prevent recurrence, providing comprehensive care for patients with diabetic ketoacidosis.